good evening, everyone.
Good evening.
Thanks for joining us. If you're watching us live, then please ask your questions in the chat. We're streaming both to YouTube and to Facebook. And so we'll see any messages that you put in the chat as we go along. We're going to just talk for about 20 minutes, hopefully no more than half an hour. So thank you for your attention. And if you're catching this after the event, thanks for finding our YouTube channel. So our topic is to talk about heart disease reversal, and Malcolm's going to do most of the talking. Discussing, the finer points of adopting a whole food plant-based diet for heart disease reversal, and drawing on our experience working with patients, clients in recent years. So would you like to take it from here?
Yes, Jenny. I've seen quite a few patients who have found Esselstyn and the Esselstyn, the heart program, and heard about the research by Dean Ornish showing reversal of heart disease. And so they found it, and they've got heart disease, and that they want to do it. And like they're going to do it. And often, there's a supporting family member, and they're going to help them too, and they're both going to do it. However, if I see a new patient with heart disease, I'll often get them to do a food diary, 3-day food diary, to get some idea of where they're at and where they might improve. And these people are often doing very well, but they're looking at the food diaries. They're not quite to target. Most often, their diets end up being unexpectedly high in fat. There's often not enough green leafy vegetables, and there's often too much bread, problem with which we'll come to later. And there's frequently just not enough food, not enough bulk. There's not enough vegetable dishes or fruits, not enough, wet, hydrated, bulky whole grains and legumes. So I guess it sort of takes us to the question with heart disease. It's like, how whole food, plant-based, Esselstyn perfect do you need to be?
I'll just interject in case we've got people watching us for the first time that don't know who we're talking about. Dr. Caldwell Esselstyn, who has for many, many years been treating people in the US with severe heart disease, and he has quite a very strict version of whole food plant-based diet that he recommends, very, very low in fat. So I just thought I'd explain that, who we're talking about, Dr. Caldwell Esselstyn.
And Dean Ornish, who back in 1990 published the Lifestyle Heart Trial, which demonstrated that the lifestyle intervention, including a low-fat vegetarian diet at the time, actually resulted in over a 1-year period of coronary arteries becoming less blocked. So the question is, how whole foods, plant-based, perfect do you need to be? That's a difficult one. Like, you could look at your health like a bit of a bank account, like, with the credits and debits. What other debits do you have in your lifestyle? What credits do you have? What was your past lifestyle like? You might have begun this as a bankrupt as far as your health bank goes. So you might not have a lot of wiggle room for scoring more health debits. And then there's your personal physiology. Now, I know the personalized medicine, people make a big thing of this and things, but I think we're all more similar than we realize. But some individuals are more prone to atherosclerosis, the clogging up of arteries, than others. I've seen women who have, had LDL levels of 4 for most of their lives, and and in later life they have a coronary artery calcium score of 0, suggesting that they haven't really done much damage. Then I've seen other people who have, had heart attacks when maybe their total cholesterol numbers only averaged 4.5 over the years. So I guess you just don't know which camp you fall into. I mean, if you're quite young and your risk factors didn't seem too extreme, then you probably fall into the camp of, I am very prone to atherosclerosis and I will really need to do everything I can to prevent this. And I guess this leads us to how low does your LDL cholesterol or your cholesterol need to be? And we'll focus on LDL, the so-called bad cholesterol. How low does it need to be? Well, the studies show that, and this is with people who have got heart disease, it needs to be lower to treat heart disease than it does to prevent heart disease. And for a long time, the target was about LDL less than 1.8. In US units, I think that's less than 75. But then there have been studies that have shown that there's even better outcomes in people with heart disease when they get the LDL cholesterol below 1.4. That's below 55 in the US units. But these were all done on people who were on a standard Western diet, who are probably overweight, probably inactive, who would have maybe been eating eggs for breakfast and chicken for lunch, and would have had TMAO in their blood and oxidative stress and an inflammatory sort of surge after every meal. What about people doing whole foods plant-based? I guess we don't really know. So, we wanted to be extra cautious. We'd still take these targets, but maybe the targets don't need to be as low if you're doing whole foods plant-based because of all the other things that it does to your, your cholesterol and your arteries. Then there's the question of statins. And I see a lot of patients, and one of their aims is, I want to get off my statins. These are the most commonly prescribed cholesterol-reducing tablets. Well, I have to say that these medications are actually surprisingly well tolerated. And over the last couple of years, I've sort of become more inclined again to prescribe them. It's always up to the patient. If you're adamant you don't want to take a statin, then don't take a statin. And there are other drugs as well, like there's another one, ezetimibe, that sort of blocks the absorption of, cholesterol, including the cholesterol that sort of spills back out into your bile, not just the one cholesterol you eat. And then there are some new, very powerful sort of biologic cholesterol-lowering agents like PCSK9 inhibitors, and all these together can push cholesterol very low. And like, how low can you go? Naturally, I've seen people with LDL levels of down, 1 and a bit, and they're perfectly well. They've pushed the numbers lower and lower, and although there's no definite point at which you're cholesterol deficient because your liver can't make enough, theoretically you need some cholesterol production by the liver to give physical form to the LDL and VLDL particles that are helping to transport fats out to the tissues to be used. But around the body, most tissues, including the brain, can make all the cholesterol they need, and I don't think as much affected by the statins as the liver is. So, that doesn't seem, there's not an obvious, too low for blood cholesterol. A note on cholesterol measurement: it's quite a variable measurement. The number, the amount of cholesterol in your blood varies. There's some error in the measurement. Most of labs will measure LDL as a calculated value. So they measure cholesterol, HDL, triglycerides, and calculate LDL, which sort of brings a sort of double or triple error into the measurement. I've seen people who have had LDLs, 10% different when they're taken 3 days apart. So bear that in mind. If your cholesterol changes a little bit between measurements, it may not be real. It might just be day-to-day, week-to-week variation, partly due to what you've eaten, but partly just a little bit random and due to measurement. Which ones do I measure? Usually the standard profile. We want to know your HDL and LDL and triglycerides. There's not much you can do about your HDL. some people talk about, well, we should be measuring ApoB because it's a more reliable measure of all the particles that might damage damage arteries. But it's sort of not a widely available measure in Australia. And if you want just one fancy number, you could just choose non-HDL cholesterol and look at that. I don't think you need to measure it. However, if you've got high cholesterol, you've got heart disease, and we're trying to think how low do you need to go, I think it is worth measuring something called Lp(a). It's a genetically determined protein. About 10% of people have high levels, and it makes the LDL particles stickier and worse. And so if you have that, you know that you need to get your LDL cholesterol lower.
Before you move on from this one, I'll just jump to the last question that's come in. What do you say to those who claim having low cholesterol isn't actually important?
Go and have a look at some of the basic research that over many decades. I think the low carbers, or even worse, the saturated fatters, those people who say, the fat in meat and dairy is perfectly, in coconuts is perfectly healthy, butter is back. No, there's a lot of research that clearly links some higher cholesterol levels, particularly LDL, with increased rate of atherosclerosis, and including some studies that actually looked at low carb, high saturated fat diets and found that they were terrible. And then, of course, we have all the data from what happens when you actually give people cholesterol medication and how it does reduce the risk of further heart attacks and things. Yeah. So it is important. Other factors are important too, inflammation, blood pressure, blood sugar control, etc., etc. Now, we would advocate for heart disease a whole foods plant-based diet at the low fat end of the whole foods plant-based spectrum. More with the legumes and starchy vegetables and whole grains rather than the nuts and seeds and fattier foods. Why would we say this? Low fat whole foods plant-based runs on the board. It's what Esselstyn uses. It's what Ornish used in his study. It's what Neil Barnard uses with PCRM when they've done studies. It's what Nathan Pritikin used, what McDougall used. So we know it works. I've often had people, and I think one particular podcast, it's like, what about good fats? I was asked. And the whole good fats thing is sort of, people often don't think of what they mean by good fats. And I would say, first of all, a good fat, I want it to be a whole food. If it's an olive, I'll consider it's fats. But if it's olive oil or seed oil, it's like it's lost all its fiber and nutrients. Not a good fat. And then I'd be saying, all right, then, we know that saturated fats are inflammatory and raise cholesterol and worsen blood sugar. So we don't want a lot of those. What's the saturated fat content like? Coconut, it's pretty bad. But some of the nuts are not actually too good. Yeah, like cashews, even peanuts, technically a legume. Even olive oil is not too good in the saturated fat department. So we'd expect something that was a good fat to be a whole food and be low in saturated fat. But I think also, Esselstyn's approach is a little bit about because he's very strict about no nuts. Part of that's a no oil, he yells out at the audience. This is partly behavioural, and we see this. Like if someone's not trying quite hard to be on the lower fat end of the plant-based spectrum, suddenly the hummus is really oily and there's cashew sauce in the day, and there's extra virgin olive oil in there. And if people are not going out of their way to avoid oil, then in our current cuisine in Australia, they're going to get a lot of oil. So our take on the good fats would be, soy is one of the legumes that's a bit higher in fat but has health benefits. So we would say, yeah, soy, great, modest intake though, like only a small amount, not the whole block of tofu, half the block of tofu, maybe eighth of the block of tofu. And then if you're looking at your
So I was just going to pick up on Esselstyn used to advise no soy products, but I believe he has softened that slightly in more recent times. And I don't know exactly what he has said about it, but I do know that there's been some really good research that's come out from the PCRM group showing the benefit of regular soy intake for women post-menopause to reduce menopause symptoms. And so we have had people who have been trying to do an Esselstyn diet for heart disease, but are also going through menopause. And so what do? And it becomes a cost-benefit analysis. And it's good to hear that Essie is now softer, but not much. Whereas we would say no cap on how many, how much you serve of those lentils on your plate. We would say if you're going to make a tofu scramble, make it really heavy with vegetables and not much tofu in there. You don't want to be eating a lot of soy. So just a very modest intake regularly, and include all the sort of parts of soy that you might be having. If you're making soy yogurt, if you're having soy milk as a condiment in either your porridge or your beverages. So that's what we understand. And there's been a comment. I wish Essie would bring out an updated edition, and absolutely we wish he would too. His book's fabulous, but we're always trying to advise people what are the known updates since he published that. It must be nearly 20 years ago that he wrote that, but we have no intelligence as to if he's going to bring a new one out. He knows that it's wanted. In fact, I cornered him at a conference about 7 or 8 years ago and said, when's the next edition coming out?
And we grilled him about the fruit, and it's like, no restriction unless you've got high triglycerides, he said. So that was a change in his program. And none of those sweet syrups and things that he had in the original recipes. Anyway, so what's our take on it? Well, there's a soy in rather modest amounts. Then there's flax, really healthy fiber, excellent source of one of the richest sources of plant-based omega-3s. But, you only have to have about a dessert spoon a day. That's plenty, ample. When I see people when they have, a tablespoon of flax and a tablespoon of chia and a tablespoon, sometimes their breakfast porridge ends up being more nut-based than oat-based. And so we would still be saying keep the nuts and seeds really low. We eat a few walnuts, particularly in our black bean brownies, and we put just a little tiny bit of tahini in any hummus we make. Occasionally we have a little bit of peanut paste in a stir fry, but we're not eating for heart disease. We're not eating for weight loss. We actually eat quite a lot of calories. I guess sort of the next thing we come to is green leafy vegetables. The rationale for these, and I'm actually a bit soft on this because Esselstyn says 6 times a day, and I'm saying, yeah, just eat them 3 times a day. It's not too much to ask, is it? It's quite nice, a side of steamed kale with balsamic vinegar. It's quite a nice breakfast entree, actually. I quite enjoy it. So the rationale for these is, the green leafy vegetables and broccoli and 1 or 2 other things are sort of very high in nitrates, which through a complex cycle in the body, even involving saliva and things, ends up enhancing the ability of your damaged endothelial cells, because they probably are damaged. They are damaged if you've got heart disease. Gives them a leg up, an extra boost in the ability to make nitric oxide and keep the arteries healthy, resistant to cholesterol, help the arteries to open up better. That sort of functions part of the reason why someone's angina with heart disease might go away, much more quickly than it would take to actually remove plaque from the artery, because the smaller arteries can open up better. But I think also the green leafy vegetables do lots of other things in the body. Like, for example, they're very rich in antioxidants. and anti-inflammatory. And so how often?
Well, I mean, I think when you said to do it 3 times a day, it's like at least. I think if you were really in a if you had serious heart disease, I might be considering, ways that you could increase even on that, like having an afternoon snack, and plate of steamed broccoli or Brussels sprouts or something that's going to do the trick. But yeah, you could question the science around the recommendation to have leafy greens 6 times a day. But we know that when Esselstyn published, I think it was 200 consecutive case studies, and out of the 179 who stuck with the program, there was one event
One small
over
stroke.
4
Yeah.
years. We keep coming back to that and saying, well, if you're in that boat with severe heart disease, we would recommend going as close as you can to Esselstyn's recommendation. But for us, we do actually eat greens 3 times a day.
And there is some rationale for that. Some of those antioxidants don't last the 24 hours. And even the nitrates, like they've done studies, placebo-controlled study with beetroot juice, actually, that found that it took a few hours for the nitrates to really start working. And they didn't work for the full 24 hours. It wore off before 24 hours. And this is a study showing a reduction in blood pressure with a higher plant nitrate intake. So there is some rationale for several times a day. I guess we might move on here to glycemic regulation, diabetes, pre-diabetes, blood sugar control. If anyone wants to keep their blood sugar entirely flat all day and have no spikes, this is a strategy of the low carb people. Like, I have to tell you that it's normal for your blood glucose to rise a little bit after meal. It also rises during and after intense exercise. It tends to rise first thing in the morning when your body's getting ready for action. So that is normal, but you don't want your blood glucose to be high for too long. And then there's the insulin resistance. And I would recommend that people, have their HbA1c measured to see where it sits. And on the old percent scale, if you're even if you're a bit below the pre-diabetes level, which is 5.7% or about 40 in the new scale, I'd like to see you well below that. Like if it was 5.3 or I'm working on this new metric scale or 4 or 35. That still probably could be better. We would like to see you more down towards 30 or around about 5% in the old scale. And sometimes I'll do, insulin and glucose and do actually an index of insulin resistance. Probably not extremely accurate. So this has a big impact on heart health. Like, people with diabetes will mostly die of heart disease. So they need to have an Esselstyn-style diet, not a high-protein, low-carb diet that will promote heart disease. And even when you've got just pre-diabetes or insulin resistance, that's still damaging to the endothelial cells. So you want to have really good blood sugar control. And if you've got insulin resistance, then you might need to start with to modify your diet for that, like to, look a little bit at that glycemic index, eat a few more legumes and make sure your grains are very much intact, so that you sort of get those slower release carbohydrates that you predominantly, you might eat more sweet potatoes than regular potatoes, or do funny things to your normal potatoes to reduce the index, like cool them or add vinegar, until your insulin resistance improves. So it would be problematic to eat things like, obviously problematic to be chugging down sugar drinks and things, but it could also be problematic to eat the too much flour products like bread. I do see a lot of diaries with quite a lot of bread. It's a nice, easy food. And wholemeal bread's actually pretty healthy, but because it's finely ground, it's rapidly absorbed, not great if you've got insulin resistance. And because it's finely ground and well absorbed, there's not much left over for those amazing colon microbes that actually help our heart health. And I guess with the bread, this brings us to the next issue. A decent slice of bread, wholemeal, sourdough, organic, whatever, it can give you up to 200 milligrams of sodium. And sodium, salt, is not at all good for heart disease. It raises blood pressure, and it raises blood pressure. And some of you might think, oh, the recommended intake in Australia is, no more than 2,000 milligrams of sodium a day, or 2,300 in the US. This is not a healthy level. This is sort of trying to get a target for the people who are eating the standard Western diet. We'd like to see ours probably down to less than 1,200 milligrams a day. So, if you're eating slices of bread 200 milligrams at a time, and then a few other condiments and things, you're going to go way over that. And there's a linear relationship between salt intake and blood pressure, from very low levels right up to very high levels. But it's not just that. There's also a direct inflammatory effect of excess sodium in the diet that will promote heart disease, even if it doesn't raise your blood pressure. So that's salt. The next really issue to look at is, like, how lean do you need to be? And, I'm always saying, like if you've got excess weight, it's not your fault, because our whole food system and the types of foods will do that to you. But you do have some, you can do something about it. And if we look at how lean people are, if we look at our ancestors, they're all pretty lean. Like, they didn't carry a lot of body fat. If you start to accumulate, more fat reserves in your body, particularly the visceral fat, the men tend to put on some fat inside the abdominal cavity, and postmenopausal women as well. Having that extra body fat will do things like raise your blood cholesterol, worsen your blood sugar control. And I think in some of my patients, that's probably one of the reasons why they can't get their cholesterol levels down, and their blood sugar control to a really excellent level, because there's too much fat, particularly visceral fat. And you can be in the healthy body mass index. And now I sound like I'm promoting an eating disorder. Believe me, I'm not. You can be in the normal range for body mass index, particularly, if you're older, if you're female too. And you can have a very low muscle mass, and therefore you can still have quite a lot of body fat. And so we can fat and thin shame you at the same time. But we're not shaming anyone here. We're trying to help people to get healthier and heal their control their heart disease. And I guess this issue of the amount of muscle on the body being inadequate brings us to physical activity, brings us to eating enough calories too, actually. Brings us to physical activity. And so physical activity, exercise, is really, really important. It's important for metabolic health. And if you have more muscle mass, then your blood sugar control is going to be better. Your weight's going to be more steady. So do some strength work, with professional advice before you start. If you've got severe heart disease, we'd say do some strength work. And for the total physical activity, we'd suggest at least an hour most days. And, a lot of this could be walking. We're not really going to delve into the effects of stress and inadequate sleep and social isolation and depression. And some of those things will have direct effect, and some of them will sort of, affect other things, like make you less active or less likely to eat healthy food. But I guess Jenny's noted in these notes.
Before you get to that one, because there's been a couple of questions and comments about, they've been, eating this way and trying to get their cholesterol down, but it's still got a way to go. And there's a couple of people who've mentioned, trying to lower it. And So, what to do. So hopefully we've already mentioned most of the things that we would recommend to do. Anything else to add
Yeah,
to those?
in 2019, when went to a day's workshop with Caldwell Esselstyn, and we cornered him a few times at that conference in the elevator. It was great. He couldn't get away there. And I actually asked him in the food line, we couldn't escape. It's like, well, what about if you've got someone and they're doing your program perfectly, and this is perfectly people, really high adherence, and say their LDL cholesterol is like 2.5, like it's not quite to target, like, would you think they'd need to have a statin? And his answer was he thought that generally they still did, that they usually still did quite well. And I'm not discounting the value of pushing cholesterol lower and even taking drugs if necessary, but I guess the point here is that this lifestyle changes the quality of cholesterol particles. You know, they make the cholesterols less oxidized. Oxidized cholesterol is much worse. The cholesterol particles tend to be LDLs tend to be of a sort of less damaging quality, not harmless, but less damaging quality. And then you haven't got all the other things happening in the blood, like the TMAO that the gut microbes make when you eat red meat and eggs. So there's quite a few other sort of dietary factors that come into this that changes the actual quality of the cholesterol particles, even if the numbers are not quite there.
So now we'll get to this question.
Can we really say that someone is heart attack proof? That's a tricky one, because I sort of think if someone's already got heart disease, they've got pretty gnarly arteries and this big lumpy scarred sort of inflammatory stuff lining their arteries. And I suppose, if you do whole foods plant-based for a long period of time, this material should stabilize. When you ask Esselstyn about aspirin, he sort of says, I'd continue it for, a year or two at least. He didn't give any definite recommendations of stopping it. And that is, it's going to take many, many months longer to sort of stabilize the cholesterol plaques you've got, so that they're no longer sort of like pimples that are about to burst in the arteries. So is anyone really heart attack proof? I mean, I would have sort of, like many things, we would sort of say, look, we can give you a very low risk. We can't give you a complete guarantee. Science and medicine is like this. This is sort of part of the reason why the non-science, what do we call them, Jenny? Nice things for people who are just not scientific and making radical claims and things and disagree with
Those
us.
people.
Those people. They'll be quite certain about what they say. And the scientists will sort of be like, we're mostly 99.9. We're never going to say 100%. So I'd be reluctant to say 100% heart attack proof. But Caldwell Esselstyn's series of 200 patients, the 179 who stuck to it, there was one small stroke, and I think there was rumour that person might have sort of gone a little bit off plan. And I guess this brings back to how whole foods plant-based, how Esselstyn perfect, how leafy green perfect, to how physically active do you need to be, how lean do you need to be. And we can't really say. But, if you're looking to not have any tickets in the heart disease lottery or the recurrence of heart events lottery, then you might need to tick all the boxes. And if you've got something like, your cholesterol or LDL will only go down to 2.5, or you find that you've got some too much LP little a, then you're probably going to have to do even better at every other category in that although to tick all those boxes to make yourself 99 or 99.9% heart attack proof.
And that just reminded me of something that that Esselstyn says. It's not just about the numbers. You might be thinking, oh, well, I had cholesterol tested a few months ago and it was, it was okay. There's a wonderful line in the movie Eating You Alive where they're talking about how hard it is to eat out, eating this way. And he says, you go out for, the ambience, you go out to be with friends, you go out for all those reasons. But he said, you'd never go out to dinner to further injure your endothelial cells. And I like to sort of think about it in that way, sort of every day, what you do makes a difference.
Every meal.
Mm.
If you have one bad sleep, that's going to sort of not be great for things, but you'll probably be fine. But it's sort of like every hour of the day, what you're doing, particularly what you eat, is either going to be enhancing the health of those endothelial cells and making you resistant to heart attacks and more heart events, or actually pushing them along down the road towards more.
So we'll get to the questions in a moment. We did just want to mention that Doctors for Nutrition are actually planning a heart disease course. Not too sure of the timeline of that, but yeah, something to keep your eyes on if you're on the Doctors for Nutrition mailing list. So there's a few questions that we haven't got to. Can any reversal influence on permanent AFib with a racing heart? Any diet? Can diet have any reversal influence?
I always think that AFib's most cases probably associated with some heart disease, some artery disease, some inflammatory changes, some damage. So I'd sort of be cautious about, I'd be assuming that my AFib was not there for no reason. But as far as stopping or reversing it, I'm not aware of any evidence, but there have been some studies, though, where they looked at people who had, procedures done to stop their AF, like they go inside the heart with a catheter and burnt the little spot that was firing off the abnormal rhythm. And the chance of it coming back was reduced by healthy lifestyle measures that were way below what we'd recommend, actually. I mean, not as adherent as what we'd recommend. I would say, though, that if you have permanent atrial fibrillation, I wouldn't mess with it. Like there's always that risk of throwing a clot off to your brain and having a stroke. So, I think we'd be saying, of all the medications, be more important. While someone might choose not to take a statin, we'd be saying, take your anticoagulant drug because of the high risk of strokes.
Just reminded me, we did talk about this in an earlier live stream about omega-3 and omega-3 supplementation increase AFib risk. So, there's a lot of factors that can go into this. Another question about, do we know any plant-based cardiologists in Australia who do telehealth? Well, let's just, before we even get to the question of telehealth, do we know any plant-based cardiologists in Australia who are knowledgeable about this? I did follow this up recently for someone, and I think in the New South Wales coast, southern, I forget what the region was called, somewhere coastal from, I can't remember what area it was. Anyway,
near Wollongong, was it south?
Yeah,
south of Sydney.
South of Sydney, that's for sure, and maybe south of Wollongong. Anyway, there was somebody who I think might be on the Doctors for Nutrition website, or has. Yeah. Anyway, we don't know that person personally. But around Australia, we get this question a lot. And do we know any plant-based cardiologists or knowledgeable cardiologists? And it's pretty thin on the ground still.
And your cardiologist should at least be positive that you're doing a healthy diet and lifestyle, even if they think the Mediterranean diet is it, whatever that is.
Well, and there's a comment come in from Anita. Hi, Anita, about a colleague of hers someone who went to our retreat. Oh, good. Whose cardiologist was amazed by their blood work and asked what she was doing, and when she told them, said, keep doing it. So let's hope over time that more cardiologists will hear this message from people who are doing low-fat, whole food, plant-based. And you would just hope that they would get curious and want to know more about it.
Even if they're just moderately supportive, or don't put it down, like, okay, that's great, seems to be working well, keep doing it, whatever it is. Because if I'm treating someone with severe coronary artery disease, I'll often want a cardiologist to sort of, to keep giving a bit of an opinion, maybe to do a stress test to reassure us that it's not negligent for them not to do X or Y or have some procedure. And most and I've had cardiologists who are not plant-based, but are right on board. It's like, okay, to the patient, yep, no, you're doing well. Your stress test is pretty much normal now. You don't need to rush in and have that bypass.
And of course, Malcolm does telehealth to anywhere in Australia. So, you could always run, your diagnosis past him and work hand in hand with your regular cardiologist.
Yeah, I'm quite happy to, and if someone has a regular GP practice and things, I'm quite happy to be just act as the whole food plant-based health, heart health sort of consultant, opinions.
I love that comment. My cardiologist told me if all his patients were like me, would put him out of business. And also a comment about, 10 months ago I lost my taste buds and smell. COVID will do that, won't it? And it's hard to enjoy. So now leaning to salty and sweet foods. Yeah,
we've seen that. We've seen that in people quite close to us about that problem, and it became particularly common with sometimes happen with COVID infections, and then sometimes someone would have been sick and then they've lost their smell, and then you're thinking that was probably COVID. I think other viruses can do that, but COVID's renowned for doing that. And that really is a problem because the smell is the nose, and of course salt, sweetness, bitterness, umami, in the mouth. So if someone's lost their nasal sense of smell, then there's a tendency to eat salty food. Maybe you could have some chili, put a bit of bite into it. You'll be able to detect that. And a little bit of, lemon juice and vinegar and give it a bit of a tang. But yeah, no, we sympathise with you on that because, although we're not sort of like, oh, wow, foodies, we do enjoy our tasty whole food plant-based meals.
So I think I've answered all the questions. So just I did mention right at the start, but some of you might have come in later. We're streaming to YouTube and Facebook. So if you're wondering where the questions are coming from and you're watching, one of them, if they're coming in through the other one. And unfortunately, the Facebook comments don't stay on Facebook anymore, which is really disappointing because, we always like to sort of create, posts and comments and have a sense of community around that. And it's disappointing. After 30 days, they delete the live stream. So, but the YouTube live stream will be, as permanent as YouTube social media is. We plan to keep them there forever. So you'll be able to watch this again later.
Forever's a long time, Jenny. Back to Tessa's question about, the flavour and leaning on salty and sweet foods. Sweet might not be too bad, if you make it a whole food sweetness. You could have it like a pineapple sweet and sour or some currants or sultanas in your vegetable dish. So some of those sweeteners, like, using a modest amount of, dates and raisins and things like that. And fruits, probably, or even mango could be quite a reasonable thing to do.
I can see a great side effect of having your taste buds numbed by whatever. She loves the bitterness of rocket now. Rocket's an acquired taste. We tend to have a handful of rocket with our lunch. So it's, mixed with other things. Okay, well, I think we've answered all the questions. So thank you all for listening in. And get in touch with us through one of our mediums if you want to, or request to be on our mailing list. We did just send out a newsletter, so I'm assuming most of you are here because you saw that little advertisement. But get in touch if you'd like to hear more from us. We're trying to do these every month, and sort of. I think we've kind of stuck to it. And we will just mention our next event is the immersion in October, and we're getting very close to full. In fact, we're getting to the stage where it's going to become a jigsaw puzzle for matching the accommodation that's still available to people who register. So please get in touch if you are thinking about doing our next immersion, because we think we'll be hanging up the full house sign before long. And as I'll say again, that anyone is welcome to request and book an appointment with Malcolm. He's a GP and lifestyle medicine trained, and as we've already said, he could be that second opinion if you've already got a team but you're a little unsure about how to proceed. Unfortunately, with telehealth across Australia, there's no Medicare rebate unless you've seen him in person. And so if you're in Melbourne, where we're based, you can book an in-person appointment with him. But otherwise, and we've had a few people do this, when they visit Melbourne, they contact us and say, we'll be there in this particular set of dates. Can they make an appointment? And that way it can switch on for the following 12 months. There'll be a Medicare rebate for telehealth.
But my prices are not super high because, I'm sort of on a mission to help people to get healthy with whole foods, plant-based and healthy lifestyle. And, sometimes I have people where maybe they could get there in person, but they sort of think, the Medicare rebate, it's not really worth all the travel and drive. I'll just stick to the telehealth and just, forego the Medicare rebate. So, I realise that, there's an issue of equity and things, but it's not always a barrier for people.
Yeah, don't get me started on the issue of equity and the Medicare telehealth rules, because we do hear from people who do not have much money, and we think it's really tough that there's no Medicare. Anyway, that's...
we also run webinar series, but we haven't got any on our books
look, I've
at the
actually
moment.
penciled to try and squeeze one in at the beginning of October before our immersion. We just haven't listed it for registration. So yes, we might be running one in right at the beginning of October, or I think the very last weekend in September. But we just haven't locked into that. We've got a bit on in the next few months. We'll let you know. Okay. Good night, everyone. Thanks for joining us. Or
Thank you for
watching.
joining. Good night.
Thanks. Good night.